pleasure to introduce Dr. Dianna Milewicz, a globally recognized expert in the field of genetic aortic disorders. Dr. Milewicz, as I mentioned earlier, is the President George H.W. Bush Chair of Cardiovascular Medicine and Director of the Division of Medical Genetics at UT Health Houston. She has dedicated her career to advancing our understanding of the genetic causes behind aortic diseases, making significant contributions to the field through her research and leadership. Dr. Milewicz also serves as the executive chair of the Montalcino Aortic Consortium, or MAC, which is the largest genetic aortopathy research registry in the world. Her work has been instrumental in identifying key genetic variants that influence the risk of aortic dissection, improving diagnosis and treatment for patients worldwide. We are honored to have her with us today to share her insights on the importance of genetic testing and cascade screening in managing aortic dissections. Thank you for joining us this evening. Let's give a warm welcome to Dr. Dianna Milewicz.
Thank you for that nice introduction, Joanna. It's very much appreciated. Good evening, everybody. I'm going to go ahead and get started on the talk. Hold on just a second. Can everybody see my slides okay? I hope. So today I'm going to talk to you about just briefly about genetic testing and cascade testing, both in terms of the actual genetic testing, but also in terms of imaging for thoracic aortic disease. And then just open it up for questions. Note that I'm happy to take questions during my presentation. I can't see the chat when questions come up. So if you have questions, go ahead and put them in there. And then, Joanna, you can interrupt me to ask questions as we go through if any come up.
Yeah.
So, hello?
Yes, that's correct.
Okay. So for many years, my research program and others have been working on thoracic aortic disease. And I'm going to just go through exactly what that is. The heart sits right here, and the big artery that comes out of the heart is the aorta. And the aneurysms form when the first part of the aorta is weak and they start to enlarge. And the major causes of that weakness are poorly controlled blood pressure, hypertension, in other words, and changes in the genes in our DNA. And so this enlargement or aneurysm is almost uniformly asymptomatic. People do not know that their aorta is enlarged, even as it continues to enlarge. And once it reaches a certain size, it becomes unstable. And that leads to type A dissection, where the blood goes from inside the lumen, inside the tube where it's supposed to be flowing, tears into the wall, and starts dissecting along, pulling the wall apart, almost like a run in a stocking. It just tears it apart. And this is a life-threatening condition when it occurs. And even if people make it to the hospital, there's still a fair amount of disability, and people end up in the hospital for quite a while after a dissection. Our current data say that of the people that have a type A dissection, 50% die before they even reach the hospital, and another 20% die during that emergent surgery to prepare this very first part of the aorta after a dissection. But so my work and others have been really focused on trying to use genetics to find those people that are at risk for this disease. And the reason I'm passionate about doing it is that if we find somebody's at risk, we can image them for these aneurysms, put them on medication to slow the growth of the aneurysm. And then ultimately, when it reaches a certain size, go in and just surgically repair the aorta. And if we do that, we can completely prevent any sudden deaths or even surgical deaths due to a type A dissection. There's another type of dissection called a type B that doesn't start in the first part of the aorta, but starts in the descending aorta. This is not acutely, does not tend to be acutely deadly like these type A dissection, but it's also a medical emergency. And the major feature that patients presenting with dissection have is acute onset of chest pain. So we want to use genetics to really identify who in the population is at risk for dissections and then get them on protocols to prevent the dissection. And so this is a quote from one of the major publications. So identification of the underlying gene triggering heritable thoracic aortic disease is powerful information that can be used to not only identify other family members at risk, but identify an individual at risk for dissection. And then it also, when we find that specific genetic trigger, it really tells us how to manage the disease going forward. And in terms of how often do we have to image the aorta? How large can we watch that aneurysm grow before we go in and repair it? And then a really important question, let's say we repair your thoracic aneurysm. Are you at risk for going on to have aneurysms in your brain or elsewhere? And do we have to image for those and treat those as part of the disease? So that's really summarize why we want to make sure that we do genetic testing when it's indicated, and also to do cascade testing to identify other members at risk. And then finally, once we've got that gene, it becomes very powerful information on how to take care of that patient and what we need to get ahead of. Remember that aneurysms and dissections of the arteries, it's basically the plumbing system of our body. And if we know somebody's at risk for having problems with that plumbing, we can go in and fix it before the pipe ruptures and causes all sorts of problems. And so that is really the goal of what we're trying to do with genetics. What's in our genes really help predict what's going to happen to a person during their lifetime, in particular in terms of diseases and thoracic disease in particular. And this just outlines that management I was talking about. If you have a genetic predisposition, we start doing routine imaging either by echo or CT or MRI of the very first part of the aorta. We put you on either on a beta blocker or an angiotensin receptor blocker, a blocker, and also important in terms of management of the disease is we want to keep your blood pressure under control, make sure you don't have hypertension. And then there's certain exercises we want you to avoid because they can cause your blood pressure to go up and suddenly. But the mainstay is that surgical repair where we open up the chest and put in a diaphragm graft into the disease part of the aorta. And the graft is shown here in white. Once again, it's just fixing the plumbing of your vascular or your artery system. So for many years, we knew that you could just have one base pair changed out of the 3 billion base pairs in our DNA. And that one change would confer a high risk for thoracic aneurysms and dissections. And we knew about that because of Marfan syndrome. And those people were studied and analyzed because of their dramatic skeletal features that they have. So it was described many years ago. The first description of a Marfan patient was by Dr. Marfan himself. in the 1890s, but by the 1950s, we knew about the thoracic aortic disease. And by the 1970s, we could go in and repair it. So now patients with the Marfan syndrome, when they're diagnosed and followed properly, instead of dying on average in their mid-40s, they can have a near normal life expectancy. So genetics has really changed the outcome. Genetics plus the surgical repair has changed the outcome of these patients. We now, though, there's other people that have many of the complications of Marfan syndrome, but have a separate syndrome called Loeys-Dietz. Loeys-Dietz, so Marfan syndrome is due to mutations in one gene called FBN1, whereas Loeys-Dietz is due to mutations, I think they're up to now 6 genes. And it can cause a wide spectrum of phenotypes, including children with that have alterations in the way their skull forms, so that they have a sort of unusual facial appearance and cause other congenital abnormalities. And these children are at risk for aortic disease starting in childhood. There's other people with Loeys-Dietz that look like classic Marfan patients, and you can't tell them apart until you do genetic testing. And then the vast majority of people with Loeys-Dietz look completely normal, but still have that risk for thoracic aortic disease. And the only way we can find these people, since we can't recognize them based on these facial appearance or skeletal features, is to do genetic testing. So we also know that if beyond just Marfan syndrome and Loeys-Dietz, that there are families where thoracic aortic disease is inherited in the family and passed from one generation to the next. And without any syndromic features, any facial appearance or skeletal features that allows them to be picked up from the general population. And John Ritter, a very famous actor in the US, died of an aortic dissection, and he it turned out he has a family history of the disease, but never had any features that like Marfan syndrome or Loeys-Dietz, where you would pick them out of the general population. And in these families, we typically go through and draw a pedigree of the family to figure out who's had the disease in the family, so we can figure out in the next generation who's at risk. So in these pedigrees, we draw a square for men and a circle for women, and then a line down for them to indicate their children. So this couple had 4 sons and had 1 daughter, and the black indicates that they have thoracic aortic disease, and the line through them indicates whether or not they died of they're dead. And in this pedigree, these individuals died of aortic dissection. So as you can see, it's getting passed down from one generation to the next. Sometimes it seems to skip a generation. Here's a woman where she's the offspring of this child, and both of her children had aortic dissections, but she herself lived well until her 80s until she had an aortic dissection. So this is the original pedigree we took of this family, but now we would color her in as black. But sometimes there's this what appears to be somebody gets the predisposing genetic alteration, passes it on to their kids, and it looks like it's skipping a generation. And sometimes they go on to pass away of other causes, but she had her dissection very late in life at the age of 82, much older than her children dissected. And then, so anybody who's affected has a 50-50 chance of passing it on to the next generation. But once somebody doesn't have it, like this individual did not inherit the gene defect in this family, and as it goes down through the next generation, once somebody doesn't have it in a family, they can't pass it on. So we know now that there's families that have this type of inheritance problem in their families. But once again, no syndromic features to pick them out of the general population. And because of this, because those aneurysms can be asymptomatic, and because we often don't know the details of our what caused our grandparents or great-grandparents to die, it's very important when somebody has thoracic aortic disease to image the family members for aneurysms. So here's a young man who died at the age of 38. He was a physician himself and was working out at the gym and had an acute dissection. And when we bring the family in and started imaging the family, we found the mother had no problem with her aorta, but his father had a very large aortic aneurysm and went to, not very large, but had an aneurysm, and it has since been repaired. And based on that, we extend the imaging and image his brother and sister, and both of those individuals had aneurysm. Now we would go on to image the children of both of these individuals and the children of this individual that died of a dissection. And that's turned Cascade imaging. And that sort of following the genetic change through a family is what we do when we do Cascade genetic testing in a family. And remember that some of these genes will cause problems, other problems with the artery. So here's a family where this individual has an aortic aneurysm, but his mother died of a cerebral aneurysm. And we often see that in families that, in particular, the women will have other problems with the arteries, including cerebral aneurysms, whereas the men will tend to have mostly aortic disease. And that is the case with the Loeys-Dietz families also. So when we start talking about of these people that have disease, who needs genetic testing? Well, is anybody with a family history or of thoracic aortic disease or dissection, aneurysms or dissection? Anyone with those Marfan or Loeys-Dietz syndromic features that also have an aneurysm? And anybody, we go on to do the Cascade testing in the family members, but we test just for the genetic variant that's in the family. And right now, we're also recommending that anybody who's had an acute aortic dissection undergo genetic testing. And that's because we find, even without a family history, without syndromic features, we find up to 10% of dissection cases have a change in the gene that we've identified. So
we do
yeah.
have a question related to that slide.
Mhm.
Sierra has commented, I inherited thoracic disease from dad. Can women pass on to kids? So far, only been passed on by males. Sierra also mentioned that she's a strong family history of aortic disease, but no gene identified. So she's wondering how to follow if any new genes are found.
I'll get to that in a minute. In families where no gene has been identified, we'd love to have you in our research program because we're actively identifying new genes, and I'll talk about that in a minute. This inheritance, this autosomal dominant inheritance, where it can be passed from generation to generation, sometimes looks like it misses women because the women have later onset disease. But when it's autosomal dominant, it means both men and women can inherit it, and women can pass it on to their children, as happened in this case. The woman got the gene, passed it on to their children. He dissected it at 27, and so did she. And this mother here, as I said, did not dissect until her 80s. So it would have been a good chance that she went on to pass away of other things had she not survived into her 80s. So sometimes you look at these families and you think, oh, it's the men only. But remember, if the majority of families have autosomal dominant inheritance, and that means both the men and the women inherited the gene and can pass it on to their children, but women will often have a later onset or may not have aortic disease in their lifetime. Still need to be monitored from it because, like I said, this woman finally dissected when she was 82, but her daughter dissected at 27. Now, her daughter had one major risk factor for a dissection, and that was she was pregnant. And not only was she was pregnant with twins. So that puts a real strain on the aorta and probably was the cause, may have been contributed to her early dissection. So, and then in terms, if we don't know the gene, we can still go through and image everybody at risk like we did with this family. Here, we didn't know the gene, but with that imaging, we picked up other family members with aneurysm. And once we know they have that aneurysm, number one, we can start following it and repairing the aneurysm in a timely manner to prevent further dissection deaths in the family. And number two, we can keep screening other members in the family through that cascade testing. So we know we have to screen the offspring of both of these individuals that were found to have aneurysms and his children and any brothers or sisters that and if he had any brothers or sisters, we would recommend screening of them too. Does that answer the question?
Yes, I think they are also wondering if any in recent months have any new genes been found.
Recent months, there are new genes, and I'll show you the progression of the genes and where we are on that in a minute. And but we still have new genes to identify. So once again, if you have a family history, they have not found the gene yet, please consider participating in research. And we'd love to have you in our research program in Houston. We've identified the majority of genes that are tested on the genetic panels. I'll talk about those in a minute. And we still are finding new genes every month. So we have a paper going in with 4 new genes this month. So, and I'll talk about how you get caught up on getting new genes tested as they come out. Okay. So one important caveat is when you go to do genetic testing in a family, you want to test somebody who has the disease. In this family here, this individual has aortic disease, had a mother that died of aortic disease, and has 2 children. We do not want to test the children. We want to test this affected individual. And if she wasn't affected, then we'd want to go back and test the mother. And you can get samples from if the person died in the hospital or had an autopsy at the morgue. There are oftentimes samples kept from the individuals in banks where we can get DNA from those samples for testing. So here's the current list of genes that cause thoracic aortic disease that are tested on the panel. So EPN1, that gene for Marfan syndrome's up here. All the TGF-beta genes that cause Loeys-Dietz syndrome are tested. And then there's many genes that have been identified, like GLOX1 and all these smooth muscle contractile genes that cause the inheritance of thoracic aortic disease without those syndromic features. So they're all on there. So all these genes have gone through a very rigorous protocol to confirm that they do cause disease and can be tested in diagnostic tests worldwide. Right now, a big issue in the field is that we have this list here of genes that there's evidence that they cause thoracic aortic disease, but haven't been validated by that expert panel to be disease causing and to be able to use them clinically. And some of them have already been moved into clinical testing, like TGFB3, but many of them are waiting approval. And we really need to figure out ways to get these genes out to families more rapidly. But despite this long list, still the majority of the 1,300 families we have in our study are still unsolved. So we're still working on solving them. And so typically when you run a panel, all the established genes, so the genes we can report out, plus all of these are tested on the current panel. So they just don't report out the results on these genes until they've been validated to cause disease. And this gives you an idea of how over time these genes have been identified. In 2011, we had probably around 10 genes. By 24, the number had doubled, and now we're up to 35 genes. But once again, we're still stuck with just the ones in black being validated as disease causing. So we really need to address these other genes and move them rapidly into being reported out on the aortopathy panels. Just because of the technology they use, it's much easier to sequence all these genes than it is to do them individually or even a subset of them. So right now, they'll report out on the 11 genes and a few of the putative genes. And in the US, that testing costs less than $250. And there's companies that offer it directly to the consumers, so you don't even have to go see a geneticist or your physician to get the testing done. As more of these genes are validated, they will go back and recheck them if they sequence them. If it's not on their panel, then you will have to come back in and get retested for future panels. So this is a major issue in the field right now, is really figuring out moving faster in the genes that we can report, because I think in the next 5 years, we'll have the majority of genes identified, and that and hopefully validated. And so the panels will be rapidly expanding, I predict, in the next 5 years, but definitely in the next 10 years. So if you're wondering if you've had all the established genes tested, if you had it before 2014, you're still missing some genes. And even if you had it in 2015, you're missing one of the established genes down here, the LOX. And then they are reporting out on TGFB3 and a few other the genes, because the labs feel like there's enough knowledge, even without that expert panel approving them as disease causing. I know it's very confusing and it's very detailed, but we're really trying to be very careful in terms of what we're using to go through families and say, oh, we need to worry about you, but we don't need to worry about you. We want to make sure we're absolutely correct when we do that. So you send your sample in. We don't need blood. You can just spit into a tube. You send it in. The cost is typically much less than an echocardiogram and much, much less than a CT or MRI. And you will get back the results. And first of all, you can get back the results that they found a variant in a gene that we know causes disease, and that variant is disease causing, which we term pathogenic or likely pathogenic. That means it's disease causing, and you can use that variant to make decisions about your care, your timing of surgery, and how much imaging you get for other vascular diseases, all that will go into managing you so we can prevent any problems in your aorta that are life-threatening, but any downstream problems that you may have, like cerebral aneurysms and things like that. And then we can start that cascade testing of family members. And they may come back and say, we found a variant, but it's benign and we don't think it's causing diseases. And there's lots of rare variants in the disease-causing genes that don't cause disease. And then finally, the thing that's probably most frustrating for people is there's variants in the gene that we can't say whether or not they cause disease or not. And those are called variants of uncertain significance. And we're working to try to figure out which of those variants cause disease and which don't. But once again, we don't want to report the wrong thing out to a family and end up missing somebody that that has the disease, and we miscalled the variant as whether it was disease causing or not. The vast majority of people that send testing, though, it won't be, as I mentioned, if it's positive, we got the gene specific management and the cascade testing. The most people will come back with negative testing. If you have a family history, it means we have not found the gene that's causing the disease in your family. And that's where you have to go to imaging everybody to figure out who has those asymptomatic aneurysms and who doesn't. And then if there's thoracic disease and cerebral aneurysms in your family, then you should be imaging the thoracic aorta and the brain for those brain aneurysms. And the VUS, we treat that like a negative results at this time. We cannot use it for cascade testing or gene-specific management, unfortunately. And this just illustrates that autosomal dominant inheritance. I think everybody had high school biology, but it means that you have 2 copies of any gene in your genome, and it means one has a change and the other doesn't. So if this person has aortic disease, they'll have that change in the genome, and then presumably the spouse would not have a change. But since you give one or the other gene to your children, there's a 50-50 chance that you'll pass on this one versus this one. And then this one ends up being affected and this one does not, because they get the other normal gene from the mother. And then this child has a chance of passing it on to the children where this child does not. So that is simple autosomal dominant inheritance that I'm sure everyone learned in their high school biology class. And so the cascade testing, I'm just going to give you an example of this. This is a family that had one of those Loeys-Dietz syndrome genes, TGFBR2. It was a family where we found the mutation in this individual. His mother had died of a cerebral aneurysm rupture, and we knew that other people on this side of the family had had dissections. So she had the mutation. And then this individual had died of unknown causes. So and had died suddenly, but we didn't know if it was a dissection or not. So we went ahead and tested his children. It turned out all of them had the mutation. It's 50-50 with any child. So it's just like flipping a coin, or the same chance of having a male versus a female child. And then this woman had died of dissection, and as had her son, but we had DNA from the son, so we could show he had it. She did not want to have genetic testing, but her children were adults and did, so we can go ahead and test them, and it turns out they carried the variant. And so this is the way we do genetic screening. Based on what happened to these 3 individuals, we would offer genetic testing to their children also. And then something to remember is, you know, if going back to her parents, did she get this variant from one of her parents? And are there uncles and aunts on either side of the family here that are at risk for aortic disease? So we've extended out pedigrees out 5 generations and for hundreds of family members to figure out how far back and how many different arms of the family are affected. There is one family that we recruited. What in the end, we had almost 150 family members that we tested for a variant in ACTA2 after we found the variant as part of our research program. Just we kept on going back further and further in the family and connected up people, found people that carried the mutation and then carried it on and the cascade testing on and on through the family. And this is just to remind you once again, if we don't find the variant, that imaging works well to figure out who's at risk. And here's a huge Texas family where this guy had a dissection and this guy was told he had a big aorta. And we've imaged everybody in the family with that little asterisk next to them and found a large number of aneurysms in this family and very large aneurysms that we've gone to surgical repair. And we don't know the gene yet, but whatever's going on in this family, we know that people can grow that aorta to a very large size because before they dissect, because there's only been this one individual that actually dissected, and people in this generation all had aortas over 6 centimeters. And so whatever this gene is, it's sort of predicting that the aorta can grow really large before the dissection happens. But we have other families where they dissect with no enlargement at all. And so until we find the gene in those families, we have found some of those genes, but not all of them. And it makes it difficult to determine who needs aortic repair. If there's no enlargement before the dissection and we know somebody has the gene mutation, we will look at the age of onset of aortic dissections associated with that gene using the MAC data, and then make a decision at what age we need to start repairing those normal aortas. So all of this genetic data, a lot of it driven by finding the new genes and then MAC defining the clinical phenotype that I haven't gone into a lot of information, but we've had a lot of publications and many more coming out to really define the careful management once we have the gene. And in some cases, it's dependent on that specific variant in the gene. But this has all been written into the new treatment, the updated treatment guidelines, and about half this guidelines deals with a genetic predisposition to this disease. So just to summarize, always test an affected family member. All the genes are tested at the same time. The testing, I haven't mentioned this, typically takes 4 to 6 weeks to complete. The 3 possible outcomes we've talked about. And questions to ask before you go for genetic testing. How much will you have to pay out of hand in terms of what are their policies in terms of billing? And then I think both the US and Canada have laws that if somebody, like if a child is diagnosed with a genetic mutation and has no features of the disease, that they cannot be discriminated against in terms of health insurance. And I'm sure that that is not a worry in Canada since you have universal health insurance. So unfortunately, in the US, it does not extend to life insurance. So one thing before you go through and start doing the Cascade screening, think about getting life insurance or long-term life insurance for family members. Make sure they have life insurance. So that's all I have to talk about. And I'm happy to answer any questions.
Sure. So we have a few questions and comments here. First question, when should children from a mother with a known gene variant be genetically tested? And if not found to have the gene variant, is there no need to be screened from an imaging standpoint?
So we recommend going ahead and testing the children because we would recommend baseline imaging to start out with any child with the variant, with the gene, with a pathogenic variant in one or mutation in one of these genes. And sometimes it can look like have a complete adult onset for many generations, and suddenly you have a child with much earlier onset disease. So we always want to make sure we pick those children up. And we think that is often because the child ended up getting some other hit that what didn't cause disease, but augmented the phenotype of the mutation running in the family. And so we want to go ahead and check children, then image the ones that are positive with the genetic testing, but you do not have to image the ones that are negative. And then the gene will dictate how often that child will come in for imaging. But then knowing the information the child has, the alteration, then you can start directing them more towards physical activities like swimming and running and bike riding, rather than to activities where they are lifting heavy weights or having blows to their chest or to their head in the case of Marfan syndrome. So we want to make sure that if a child has the alteration, that they are doing the appropriate sports and not something that's going to put their aorta at risk, and in the case in Marfan syndrome, their eyes at risk. Because a blow to an eye, a hit to the head of a basketball or a soccer ball in a patient with Marfan syndrome can dislocate their retinas and cause blindness in an eye. So we really want the rest of the genes, that's not a worry, but with Marfan syndrome, that is.
And another question, my husband survived an aortic dissection and had genetic testing. Nothing was identified related to this. Now we have 2 kids. How often should they be tested?
Well, they should, if you did the genetic testing in the dad, they don't need to be tested. And in terms of imaging, I would get the baseline image, and if it's completely normal, maybe repeat it in 3 to 5 years and continue to do that well into adulthood. But then at the age your husband had his problems, I think that if everything's still completely normal, you can be less worried about continuing the imaging.
And how often should someone's teenage kids be screened if there's an unidentified gene in the family?
So if the gene is causing later onset aortic disease, the teens can be screened. And then, like I said, screened at an interval. Certainly, if let's say you screen your 12-year-old and then a couple of years later, they decide that they just have to be on the rugby team or on the soccer team, then go ahead and rescreen them before you let them play competitive sports, just to make sure everything's okay. So some of that is working with your doctor to determine when to rescreen. But once again, even for children, we would recommend 3 to 5 years to come back if everything's normal. And we haven't found a gene causing the disease in the parent.
Okay. Another question, do you think diagnostic laboratories will implement genome sequencing instead of panel testing in the future?
Yes. And that's because, like I said, we have more than half of our families are still unsolved. And so we just are getting back. So we previously did something called exome sequencing, where you're just sequencing the genes, but only limited parts of the gene. So we have sent our entire cohort for whole genome sequencing. And now we know that there are variants in the genes that are not picked up based on routine testing or even by exome sequencing that we can only find by genome sequencing. And we have a paper that's in press now where we took families with classic Marfan syndrome that underwent genetic testing and they were negative. We did exome sequencing on them. They were still negative. And in genome sequencing, we find variants out that are still within the gene, but deep buried in areas that are sort of unexpected. But then we can show that it ends up altering the protein that's made from that gene. So if you're a Marfan family that's or if you have many of the features of Marfan syndrome, many of the features of Loeys-Dietz, and have had negative genetic testing, you might talk to your doctor about moving to genome testing. And sequencing is one of those things where the price is falling rapidly and continues to fall. And soon, and the plan for the research, at least the research program I run, is that we want to find all the genes that predispose to dissection, because we're going to go to whole genome sequencing as part of your medical care so that we can do much better in predicting diseases. And so sooner or later, the diagnostic testing will be all genome sequencing, and then it'll be part of just routine medical care.
Okay, so we have a question from Sierra. Sierra has a strong family history of aortic disease, but no gene identified. They haven't found her gene. She would love to participate in a research program. She had sent samples a long time ago. Says Ellen Hosteller was the researcher. They are in Australia, but very keen to participate. She is asking, can my family rejoin the research gene testing? We previously were 5 years ago a part of it.
Okay, you're still a part of it. That was part of the consent, that we continue to work on your samples. And your samples were sent for exome sequencing, and now we've sent them for genome sequencing. And once we find something, we will contact you. If you have questions, go ahead and email me, Dianna Milewicz. You can find my email on the web, and I will forward it to the genetic counselor. Ellen was our previous person in this position, but now it's a woman named Gopika, and she's a certified genetic counseling and counselor, and she's happy to talk to you, get an update on your family and what's going on in your family, and then update you in terms of where we are with your family. So feel free to go ahead and email me right now, and you'll hear from Gopika tomorrow. That's true for anybody that's participated in our research study. We don't have time to really send out routine updates on the families, but once you enter the family, we have your samples and we continue to work on them.
Sure. So we have a couple of questions asking for that email. So I put the email in the chat. If those of you watching are not able to see it, it is dianna.m.milewicz@uth.tmc.edu. And you should be able to readily find that on the internet, but I've also placed it in the chat here. And also feel free always to contact GATA as well, and we can connect you. Another question here.
1 second, I've also put in the MAC email, so
Okay.
feel free to use that. Also, if you have a mutation in a known gene and you want to participate in the Multichino Aortic Consortium, also if you feel uncomfortable emailing me, or if you don't hear back from me, because I get about 500 emails a day and I have a filter, and sometimes the filter ends up, screening emails inappropriately, go ahead and email this MAC, because Ernesto, the person that oversees the MAC consortium, and Gopika work together to monitor all the requests that come in. So
Thank you. I've copied that
Oh, thank
in the
you.
chat as well. mac@uth.tmc.edu. So that is in the chat as well. So please copy that. Another question for MYH11 gene variant. Is it recommended to have surgery sooner as it is in Marfan's or EDS?
Yes, we have those recommendations coming out. We collected data once again through MAC to define what variants in that gene are disease causing, and that was really tough because there's thousands of variants in that gene, and only a few of them actually cause disease. And so once we could define which variants cause disease, then we can look at the phenotype, and we're coming out with this. If you email MAC, we can go ahead and send the recommendations, which are in a manuscript that's been submitted for publication. And once again, that's coming out of the Montalcino Aortic Consortium.
Another question, will these screens be covered by most health insurance companies in a family with history of dissections but no gene identified yet due to lack of testing?
The screens in terms of the imaging?
I believe so.
Yeah, the insurance is, so the reason we write those treatment guidelines and why they are condoned by the American College of Cardiology and the American Heart Association is that it's meant to set the standard of care and what insurance companies should cover. And so all of this that I talked about in terms of screening relatives, and if you have one person in the family, go ahead and screen the first degree relatives and the Cascade screening. Once you know something's running in the family, all that is part of the treatment guidelines. So your insurance should cover that.
Okay, great. Well, there are no more questions here.
Good questions.
Yes, very good questions.
Yeah.
And if anyone attending has any more questions, feel free to email info@gadacanada.ca and we'll be sure to pass those on. I'm just going to type that email in here.
And so please participate in our research, either MAC or Gene Discovery, and support GADA because they do help us fund this research. And everything that I talked about is based on people that take the time and effort to participate in research. And it's like playing it forward, helping what you contribute helps not only your family, but helps many, many families out there. So thank you for participating tonight and for the great questions.
Yes, thank you all for joining us this evening for GADA Canada's webinar. We are incredibly grateful to our expert panelist for her invaluable insights about genetic testing. It's through events like this that we hope to continue to empower individuals, families, healthcare professionals with the knowledge and resources they need to better understand and manage genetic aortic disorders. I'd also like to acknowledge the generous support of the Temerty Foundation, whose funding allows us to continue advancing education, research, and patient advocacy in this critical field. We encourage you to stay connected with GADA Canada for future events. Please feel free to email us. And also remember, if you have any further questions, the email is here on the screen, and be sure to copy the emails for MAC if you are interested in joining the research program. Thank you for your time and participation, and thank you, Dr. Milewicz, as well for your time and for the presentation.
Thank you.